for this panel, I would like to invite Mr. 𝗣𝗵𝗵𝗪, CIO, Rajiv Gandhi Cancer Institute and Research Center to the stage, Dr. 𝗪𝗵𝗵𝗪, Vice President, 𝗧 Medical Technologies, Mr. 𝗧𝗸𝗵 𝗪𝗁, CEO, Alkem MedTech, Mr. 𝗪𝗵cie 𝗂𝗹𝗪, Head Enterprise Solution Consulting India, 𝗪𝗵𝗵. This session will be moderated by Dr. 𝗪𝗵𝗵𝗪, SVP Chief Information and Digital Strategy Officer, 𝗪𝗵𝗵𝗪 Health System, New York. A huge round of applause, everyone, for the panelists.
Namaskar. Good afternoon.
You got 10 minutes.
While the panel members are settling down, I want to thank Vishnu and Aarti for inviting me. When Vishnu texted me that we are doing DHN in Delhi, I said it will be a good nostalgic moment for me. So, by the way, my name is 𝗪𝗵𝗪𝗪. I am a practicing internist, confined to hospice care and in addiction medicine. And in my part-time, I am the Senior Vice President and Chief Information and Digital Strategy Officer at 𝗪𝗵𝗵𝗪 Health System in New York. I continue to practice medicine and my team does all the other work. Coming to Delhi is very nostalgic for me. I did my internship at 𝗪𝗪𝗪𝗪 Hospital, not too far from here. And during my internship days, this hotel was actually being built. So good to be back in Delhi after so many years. Obviously, Delhi had changed for good. Maybe the next few seconds, I would request all the panel member to introduce yourself, and then we talk about, although this panel is both on the virtual care and the remote patient monitoring, I think for the sake of time, we'll focus mostly on the RPM side, because virtual care in of itself is a 3-day conference, so it does not justify our 20 minutes. So with that, from my left, Mr. Dwivedi, please introduce yourself, what you do, and so that we can ask you appropriate questions.
This is 𝗣𝗵𝗵𝗪𝗪, CIO of Rajiv Gandhi Cancer Institute and Research Center, Delhi. Very grateful for the invitation to share the panel with esteemed co-panelists and speak in front of so many august attendees like you. I know many of them are so senior and experienced, so it is humbling to be with you. Thank you.
Good afternoon, everyone. I am Dr. 𝗪𝗵𝗪𝗪𝗪. I am Vice President, External Affairs with 𝗧 Medical Technologies. Apart from that, I am also the Joint Forum Coordinator for IMED, which is the Association of Indian Medical Devices, which is one of the industry sponsors here.
I am 𝗪𝗪𝗪𝗪𝗪𝗪. I am the CEO of Alkem MedTech, which is a wholly owned subsidiary of Alkem Labs.
Hello. Hi, I am 𝗪𝗵𝗪𝗪𝗪𝗪 Satishan, representing 𝗪𝗵𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪 and I'm happy to be here at the DHN Forum. Thank you.
All right. So if you have to learn one word today from this panel, obviously you're going to learn many strategies or policies from our esteemed speakers. Please, when you go back home, I personally don't like the word RPM, which stands for remote patient monitoring. For me, this is called patient remote management, because we are not only monitoring, we are managing these patients. And we are patients either managing these patients either within the walls of the hospitals or at home or in somewhere in between. So with that, let me, by the way, I have a script, so I can't even go without the script, but I'll make sure that these dialogues goes off script today a little bit. For the first question is for you, Dr. 𝗪𝗪𝗪𝗪𝗪𝗪𝗪.
Yeah.
But my other panels, please chime in because we need to go off script. It's not only that the questions are for Rajiv, and if you feel very strong that you know the answer better than Rajiv, please chime in. So feel free.
That's not the question exactly.
No, I'm coming to the question, but I'm just giving you the ground rules, you know. The first question for Dr. 𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪 is in the cardiovascular space. From EKG monitoring to any devices, where do you see the remote patient management in cardiovascular is moving along? Or any words of wisdom?
Yeah. No, see, CVDs or cardiovascular space has actually gone a lot from where it traditionally was. It started with the bare metal stent, which was, barely able to have some kind of an impact. But then it moved on. And today we have, companies which look at innovation from a very, from a 40,000 level altogether. Look at SS Innovations. I'm taking names. It's just not, because of the sake of, giving a credence to a company, but they would be able to monitor and also prescribe something which I would say relieves not only the entire patient agony from moving wherever they are to which is why remote monitoring is done, to also looking at data deciphering at a level which can otherwise be analyzed when the patient is not there. See, what we need to really look at is the outcomes, and the outcomes come either before the patient reports reach the doctor and the doctor analyzes and then you interact with the patient, or once we've interacted with the patient, we decipher something which gives credible data usage in terms of further research and innovation. Now, that particular part is something which needs to really be built into patient-centric orientation. And this is where I think remote monitoring can actually happen in not only cardiovascular diseases, and these are high-end diseases that we're talking about. Cancer you can talk about. You can talk about, other ailments that we are really looking at and which really falter to a level where we need to not have, the patient in front of us. We can actually look at things and, skim the data. The doctor has given you the idea that how to move around. But it needs to be more research and patient-oriented in terms of its orientation that we're looking at.
All right. So please, it's not remote monitoring, it's remote management.
Remote management.
Yes. Please go ahead.
Yeah. See, first of all, thank you for inviting me. Since you said let's go a little off the track, and just to give you an insight, I have grown in the MedTech industry for last 27 years. We have only seen a movement from analog to digital in the hardwares for the last 6, 7, 8 years, or at most 10, 15 years. But one hardware or one specific disease segment was always relying on data was pacemakers or implantable pulse generators, which, later on you had the heart failure devices and the neuromodulation, which was basically an offshoot of a pulse generator for the cardiac rhythm management. Now, this is where we have seen the remote patient management first came in through technologies where a patient was given a passive sensor and the information was picked up ambiently, even in a passive way, and there is an opportunity of transmitting. But in that situation, what we have realized when we introduced it, say 15, 20 years back, we found that the bigger problem was in the interoperability within the system. But because all the digitization we discussed among health infrastructure has been more focused on the electronic health records, which is necessary because that's the basic foundation. But the system talking to each other, and also what do you do with an alert when a patient is lying and a heart failure symptom comes? Do you have a clinical workflow which determines, okay, this particular individual will be responsible to reach out to the patient and call that person to the hospital? Perhaps no. And one thing we have not actually addressed even today on this particular area where remote management of patient is happening, the medical legal liability that can come on the hospital if you have an alert and not respond to it. That's an unanswered question.
Correct. So those are policy questions, and reimbursement questions will come a little bit later. As Dr. Rajiv Chibar mentioned, it's not only cardiovascular, you have oncologists also. So we do have an oncology specialist on our panel, and I will request Mr. 𝗍𝗶𝗪 to... Oncology care is very complex, not only from the inpatient side, but also when the patient is discharged in terms of pain medication management, palliative care, and also coming back to the follow-up. So, Mr. 𝗍𝗶𝗪, how do you feel personally and at your institution the role of remote patient management and how it can enhance the oncology care journey?
So first of all, a small correction. I'm not oncology specialist. I'm oncology IT specialist. Doctors will mind it if I claim.
We gave you an honorary degree today, so.
Okay, now coming back, I'll go a little deeper. See, according to ancient Ayurveda text, there are 4 pillars of treatment. Number 1, patient. Number 2, doctor. Number 3, medicine. And number 4, attendant. So the other 3, patient, doctor and medicine are there. Attendants are vanishing. Our social fabric is breaking a little bit. We don't have time to take care. So we are looking for technology to fill that. This is the honest, need for the technology. Now your question is very loaded. You said remote monitoring or remote management.
I did not say monitoring.
Right. The second is pain management, and third is the adherence to the prescription, what was written. See, when we talk of the remote management, we invariably think of technology, building robust network, doing the continuous monitoring of vitals, and then some alert system, raising an alarm and all that. We are not looking at very basic things. What happens when discharge happens? The attendants are very much focused on how much is the bill and how to get discount and all those haggling, and how fast to arrange the logistics to go home. So half of the time the due attention to the discharge summary is not given. The patient is not very clear, not have understood clearly what is the treatment regimen to be taken. And in cancer particularly, as you said, situation is complex, the immunity is very low, and things can go wrong very easily. So there are 3 modes of treatment, the surgery, radiation and chemo. And post-discharge care is very different for all the 3. So we have very different kind of needs. See, in my opinion, we are working with a Japanese company. They are creating curated content based on the discharge summary. It is very specific. And when you create a video, that patient can listen again and again and again at his or her own pace, or attendant can listen, it will be very easy to adhere to the instructions those that were given in the discharge summary. And even prior to that, there are discharge summary validations also. So maybe if there are some inconsistencies in the discharge summary itself, the AI can flag those things and can help. Then you can actually add the technology components of at least somebody putting the vitals in the system, or there are some wearables, or there are Bluetooth-enabled devices that can be used maybe 3 or 4 times a day. So these are very simple applications according to me. Thank you.
Thank you. So even if we have very sophisticated medical devices, very good internet systems, and having smartphones or any devices at home, you need an enabler. So my next question is to Dada, call him Dada. From the implementation perspective and also from the interoperability, where do you feel the medical devices in particular, not the other part of the care journey, how do you feel as an implementer or enabler that without you and your team or people like you, it will not be successful?
Okay, yeah. So I think I am the odd man out, so I feel like representing the IT industry here. So yeah, a very valid point of interoperability, right? So different devices came in different times, have different way of giving data, right? So the reliability of data, which I think was already spoken of, what I would like to add to it is the security, right? Of course, the compliances and all, I think we are still growing. When it comes to India, like we don't have something like HIPAA, right? So things need to be taken care on that front. So whatever devices from which we are getting this data, how reliable it is, how secure it is something we need to take care of. So as I said, from the IT point of view, would say that whatever devices we are talking about, we are mainly talking about wireless devices. So a need for a very robust and secure wireless. That is basically what is needed, because now we are talking about robotics and all, right? And when it comes to surveillance is no more about just monitoring, right? So you take a decision based on AI. A very simple example is, suppose you don't want to allow in ICU anybody without a mask, right? So a camera can actually detect it and alert it, right? So that's a very simple use case. Proactively using AI, right? Through the surveillance. So yeah, so I would stress on the cybersecurity need of thing, a secure wireless, and using AI along with the IT component of things.
So to the point, you definitely need a very secured environment, whether it is 5G or 8G or Wi-Fi 7 or above, and definitely they need to be very, very secured. But again, these come with a cost. So my next question to those who are in the audience, policymakers or from the payer side, these can be very expensive, but these comes with a cost. So are there any words of wisdom from any of you, maybe each one of you, what we providers in this country needs to think about who is going to pay for these services? I'm talking about from post-hospital care to the doctor's office and somewhere in between. So maybe from my right, if you can give like a words of wisdom on the reimbursement side and also anything on the policy side.
Yeah. So see, first of all, we need to optimize whosoever pays. There is a saying in Hindi, छुरी गिरे या तरबूज, कटना तो तरबूज को ही है. So basically, ultimately the patient pays, right? So we need to economize. We need to find pragmatic solutions. See, for even remote management also, it is not necessary that you take patient home. Maybe there are nursing homes and there are guest houses which are close to the hospital that can be very easily approached, and the intervention can happen from within the hospital. So some of the innovative solutions need to be worked out to economize.
So you are absolutely correct. The hospital at home concept is emerging, especially for the payers who are the third party payers, not the patient who is coming paying out of pocket. So very rightly said. Anyway, nursing home or guest houses or anything near the hospitals are good to value.
So I'll actually try to relook into it. I mean, what he said is something very valid from a hospital perspective, or even ultimately the patient or the caregiver perspective. But from a policy perspective, see, what the government has actually started to accelerate on is the entire HTN formula, the health technology assessment formula that they're looking at. Now, the HTAs are right now limited to only the devices or maybe, a particular procedure per se. What we need to move from, the reimbursement of not only devices is the entire service quotient
cycle. Yeah.
That needs to be given, and this needs to be taken care of. And when we're talking about management, see, I break management in a very different formula. It's like the word itself is enough. So manage, men, T is for tactfully. So if we can actually use that tactfully for technology, the entire cycle, right from when the patient is inducted in, the procedure done, maybe a remote monitoring done, your management within the hospital done, as per him, the discharge done, churi to girni hai. But let that slicing also happen for the next 10 to 15 days. The entire procedure gets over at a cost of not only your services, but at a cost of the health also.
Correct.
So if we can have those services which can be provided at maybe a guest house or a home care device, also covered and reimbursed, is what forward thinking is going to happen. It started happen. Israel is doing it. We've got a lot of European countries. The Scandinavian countries actually post operation, you get 10 to 12 days when you're actually getting all of those services, and that's all covered under your insurance reimbursements. What does universal health coverage call for? Or what would digital health mission call for? A digital health mission needs to look into a 360-degree regime in that sense. So I would go into a policy perspective.
Correct. So in between the patient and the management, there is a very complex thing which I would request for the medical device, because it has to be interoperable. You just can't have a device in its own, EHR is on its own, and the patient is whether using phones or whatever device. So from medical device perspective, any last final thoughts?
Yeah, so two things I will add here. One thing that we need to look at is what is something we are trying. When you kind of design the device, it's important to co-create it along with the HCP, which is a healthcare professional, whether it's the nursing or the doctor. Are you really solving a real life problem? Now, once you do that, the other thing that we need to work on, see, India still today make an assessment based on brick and mortar ways of the erstwhile, the way we do any other procurement. We don't have an health technology assessment where we do health, kind of a, I would say health economic and outcome research study. Because we don't do that, and this is something which is an established way of, approving any device into any health reimbursement system globally. Whether you look at, even take the example of NICE, take the example of the Japanese reimbursement system, take any reimbursement system, it is all through, a health economic study and outcome research, which is not yet happening in India.
I did not want to hear that bell. So anyway, my last words of wisdom from Sumit is, can you give us one or two very good use cases of remote patient management, not monitoring, coming to India or is already going in India?
So again, when it comes to IT, what we can do, in fact, I've been discussing offline also. So if at all, so if I have to combine 𝗏𝗏𝗧𝗏 sir and Dr. Chibber's, so I think I like that insurance coming into picture, right? So that is to answer the last question. And 𝗏𝗏𝗧𝗏 sir said about basically having a separate guest house, right? Maybe you can have, just like you have co-working spaces, you should have a different patient monitoring ecosystem, which is not a hospital, right? All this ruckus is about not being in the hospital post-operation, right? That's the whole point, right?
Right.
So I think combining that together, insurance, paying the churi, matlab, wo katega, but then maybe insurance shells out something out of it, right? As far as the IT is concerned, I would say the IT is ready to give systems, like if you have, like, the reason I was saying that you should have special space is that from there the connectivity needed, the secure connectivity needed, even if it is a rural area, we have like SIM-based routers which gets connected to the main core, right? And like there should be a command and control where continuously doctors are monitoring multiple guest house patients, post-care patients, and yeah. So that could be technology enabler.
Yeah. So in the interest of time, I have to stop here. I mean, we could go on and on and on. I want to thank each one of you for giving us at least thought-provoking action on the future of remote patient management, not remote monitoring. And also, those who are hospital leaders here, this is a good diversification of your portfolio to get into that business. And you can cross the boundaries maybe globally to provide the patient remote patient management. So with that, thank you so much, all of you. And hopefully looking forward to the future of the RPM in this country.